rewarding. We saw a patient last week which fits your ICID, 40-year-old, and Dr. Muhammad Al-Rajah, our fellow, actually put a monomonoca stent. But when I saw her 6 months ago, she was quiet and she had the typical features. Now she has some inflammation in the conjunctiva. Have you followed these patients for a long time and saw progression?
Yeah, so if it fits the category of ICID, I have followed, I think till now I have 14 patients, and I have followed them for beyond 2 years now. And all of them went to stage 5, in spite of everything that I could do. You know, I did all the possible things in the armamentarium of a lacrimal surgeon to avoid them getting closed up. So that is where I feel that there is a need to be going a little more basic science and understanding what is it that is making it. I scanned their bodies for all the autoimmune diseases, so extensive workup. I might have spent at least $500,000 rupees into these 14 patients to find out what's going on with them. So as of now, if you follow them up for a long period, they would do bad if it is ICID. You know, and we unfortunately cannot do much about it as of now, unless some bright guys sitting here, you know, think about it and come up with some solutions. But as of now, it's very bleak.
What we noticed is that she developed generalized inflammation in the conjunctiva. So you haven't noticed that in any of your patients?
So no, I didn't have that one as of now, but one of the patient had a focal conjunctival inflammation just around adjacent to the punctum. And you know, for me, every small signs or symptoms which is a little away from each other, I really go behind it. I got that back, and I again started not only looking for the histopathology. I wanted to look up for a lot of fluorescent antibody markers, whether there's some chronic inflammatory conjunctival disease that's happening which we are missing, or it is showing first in the canaliculus. We didn't find any of those things, and a lot of those antibodies were negative. But we did find chronic inflammation in that area histopathologically, what we saw. Again, that correlates and corroborates with the chronic inflammation that we noted in histopathology of the canaliculus. So something you know, which I think we need to really work hard and put our brains together to find some way out of this disease. I'm sure in a period of 4 or 5 years, somebody would come up with something for this. Yes, sir.
Thank you again, Dr. Javid, for an excellent lecture. Just asking about those patients that you spoke about, I said, is it related to viral infection? Because I saw patients with viral infection end up with the canalicular stenosis and obstruction.
Yeah.
Is it related to them?
Yeah, so the two viruses which are very well known in this one is herpes simplex and other one is CMV. Both these viruses are known to cause canalicular obstructions, but what happens with those are very typical. I'll probably you know, give you one of my papers which actually talks about how viral canalicular infections are different from that. But the point is valid and taken that in the beginning, if it comes in the proximal canaliculus, it would exactly look like the same thing. And that is one of the reasons the major criteria that I have mentioned is that a microbiological evaluation should be negative. By PCR, you should not be able to find any bacterial or viral products to call it ICID. So the criteria to call ICID is a little stringent. Some people may also have similar findings if they have chronic blepharitis or mebomitis as a secondary you know, canaliculitis, inflammatory canaliculitis. So all these findings should be a way for us to call it ICID. Because most of those conditions, if you treat blepharitis, things will get all right. You know. Yes, ma'am.
Thank you. It was really impressive. Although I'm retinal specialist, but I like oculoplasty from your presentation. Now, my question really, I get embarrassed because of the presence of acetylcholine. We know that acetylcholine is a neurotransmitter and mainly work on the nervous system. So I just, my question to you, just to increase my understanding, is the same material, the same sensitivity of the receptors, and what about the pharmacological effect? Does work in the canalicular disorder like in the neuro, as in other nervous system disorder?
Yeah. So as of now, these sources of acetylcholine are called as non-neuronal sources of acetylcholine, and we know very little about them as of now. One of the areas where it is known to is in the GIT, non-neuronal, and where they are known to have paracrine effects. So one cell liberates acetylcholine, and that goes into the surrounding systems and acts on the surrounding tissues. So what they found, for example, in urethra, is that once this cell releases acetylcholine, there is immediate contraction of the urethra from the bladder, so that nothing comes, no more bacteria comes into this area. So what we know as of now is that the acetylcholine is the same molecule, the receptors where it acts is the same, but it is not liberated from the neuronal nerve endings, but it is liberated from the epithelia. How does it act? Unlike neuronal, this neuronal mostly act like, for example, neuromuscular junctions. Here it acts via paracrine effect. It just goes to the epithelium and creates what it needs in that area, or say inflammation. If there are fibroblasts in that one, it will convert them to myofibroblast. It will call a lot of cells, the neutrophils and granulocytes, into that area. So these are the ways it acts as of now, but very little is known about non-neuronal acetylcholine. And that's the fun. If we know less about things, it's real fun to be working in these areas.
You mentioned that in postmenopausal women there's changes in the canaliculi related to the hormones. Does that also play a role in the dry eyes that many of these women have?
Yeah.
And will this be the future for the treatment? Will you be able to tackle both the dry eyes and the canalicular obstruction, where the etiology is basically the same?
Exactly. So very interesting paper that I was telling Adil probably 2 hours back. 2 hours back, there was a paper that came on PubMed which talks about the nasolacrimal duct systems of the lizards. Okay, and how they have evolved, and those lizard species which does not have lacrimal glands also do not have nasolacrimal ducts. So the point I want to drive home is what Dr. Hussain was saying, is that these are interconnected. They are ultimately part of the entire lacrimal system. So we now convincingly know that for women to have dry eyes is secondary to loss of estrogens, and that's where a lot of hormonal therapies, or women who have dry vaginitis, when they have been on hormonal replacement therapies, have shown a concurrent improvement in their tear, dry eyes. So the pathophysiology is, even I believe, is somewhere the same. And if we are able to crack this mystery of taking care of these hormones by hormonal replacements, or how I think we'll be able to take care of both the dry eyes as well as the lacrimal issues in women. Yes, sir.
About the stages of the ICD, yeah. And you mentioned that it is progressing like a membrane until block. So away from the etiology and what you did as a great, I would like to know, is there any possible local treatment, as we do in the retina, to use an anti-VEGF or anti-inflammatory advance like biologics, in dealing locally with this before that progress to full obstructions, or making the punctum that blunted? Yani. So thinking in the way that you are thinking, how to go in the future for treatment. In uveitis and the retina, we do use a lot of these products with the local therapy.
Yeah. So that's an advantage of working in systems like this, because you have a lot of people who will be coming up and giving up fantastic ideas. We have done that only in 2 patients so far. We have used VEGFs, and we have used VEGFs in the stages of where we found vascularization, the stage 2 and stage 3, because ultimately the membranes are vascular membranes. Ultimately they become solidified. So what we found when we used very local injection of that is that it reverses the vascularization, but it was not reversing the edema and inflammation. That was what we were, and once it's withdrawn in period of 3 weeks, again it was coming back to it. So we actually do not know, or at least I have not thought about the schedules of how am I going to persist with anti-VEGFs. And fortunately, our retina department, it's like has 12 separate departments. So there is a department of retinal vascular disorders. And those guys have a hell lot of this anti-VEGFs lying in stock where we can beg, borrow, or steal from them. And that's where I'm trying to use that. But that's a fantastic idea that we have pursued it. I'm just looking for some combinations where I can reduce that edema.
Steroid could help, and
Yeah.
anti-VEGF in the same times as anti-angiogenesis and viral.
Yeah, it's a fantastic idea, yes.
Thinking about nanotechnologies, especially for the small areas, it might be slow release and
Yeah, so with regards to nanotechnologies, we have been successful in now creating a formulation using PETM dendrimers and PAMM dendrimers, where I was trying to use either these dendrimers or apoferritin, and I wanted to combine them with steroids and combine them with sometimes with mitomycin C where it is really needed, where I wanted to coat the stents with these nano-coated drugs so that they can release a little longer. So if we are able to do that, at this point of time, we are not able to retain the drug on the coating beyond 3-4 days. And second thing is that it's a very erratic release that's happening. It's releasing, but it is releasing erratically. So if we are able to do that, and if we are able to coat it well, then monocas, which are coated with steroids or immunosuppressives, could be the next way to, rather than plain monocas and using steroids topically. So, yeah, that's another fantastic idea. I think residents should come up. The girls are very silent today. The residents should come up with a lot of bright ideas. I'm sure something is boiling in your minds. And believe me, my experience is that the idea that appears the most stupid should be pursued with most aggression, because that's what is going to lead you most likely. What appears that this is not possible, that is something that will take us forward. So I again, ask a lot of residents that, you need to be clinician scientists. I have operated 3 heads of states in from 3 countries, at the age of 35. So head of state would not come to you if your skills are not good, surgical skills, right? But that should not make us happy. We might be the best surgeon on this planet, but it doesn't carry weight unless we are able to translate the problems of the patients, take it to the laboratory, find solutions, and take it back to those patients. So unless we do that, and this is the future, molecular medicine and molecular science is the future. If you really want to be the top in the world, and if you want to walk the aisles of American Academy and you want people around you to respect you for your work, this is what we need to do. And we know that this century is Asia's century. The domination of West has ended. So this is a very good opportunity for all of us to really buckle up our shoes and carry the science forward.
Okay, thank you so much, Dr.
Thank
Ali,
you.
and thank you so much for attending.
السلام عليكم. Do you want to take the quiz now or after 10 minutes؟ تصلوا ترجعوا؟ الآن؟ طيب خلاص أجل please be seated.
جزاك الله خير.
حضروا الامرجنسي دكتورز موجودين؟ والستارت؟ وين محمد السماري؟ محمد السماري؟ جا زملائك؟ خلاص؟ طيب سموا الله بسم الله. اوكي ان شاء الله the quiz is easy. يلا. First slide, a 45-year-old with this following lesion for 3 weeks. What is the diagnosis? And list 5 possible causes. 5 possible causes. Okay, next slide. What is the diagnosis? What is your management? Straightforward cases. يلا. Next slide. Okay, what is the diagnosis? You have a slit lamp photo and you have an anterior segment OCT. Okay, so what is the diagnosis? The second question is, what is the nature of fluids during the intraoperative phase, during the early operative phase, and the late onset phase? Okay, so 3 different types of fluid. Mention each. During the intraoperative phase, early post-operative phase, meaning أول أسبوع تقريبا, and then late onset. Okay, fourth question, number 4. What is the diagnosis? And then where do these lesions arise from? So we know it arises from three different possibilities. So what are these different possibilities? What are those 3 sites of origins? And which one of these carries the highest risk for metastasis and death? Okay, so the diagnosis, what is this? And where does it arise from? It either arises from something or something or something else. And which one of these has the highest risk for metastasis and death? No, this is unilateral. Okay, it is unilateral, and you can see the lesion clearly, and you can see what kind of lesion is it. خلاص. So these particular lesions, we know there are three possibilities. It either arises from, or from, or from. Okay, so three different possibilities, and which one of those three has the highest or carries the highest risk for metastasis and death? Are we okay? Okay. Last slide. Okay, question 5. Diagnosis. Mention 3 ocular associations. What is this congenital anomaly, huh? Okay, I'll go through the slides one more time. طيب. أول سؤال. This lesion from 3 weeks, what do you call it? What are the 5 possible causes? Question 2, what is this? Straightforward, huh? What is the management? Question 3, what is the diagnosis? Looking at the OCT, it's clear. What is the nature of fluids during the intraoperative phase, during early post-op, and late? Last, 4th question, what is the diagnosis? Where does this lesion arise from? And which one of these areas of origins carries the highest risk for metastasis and death? Last question, what is this congenital anomaly? What is the diagnosis? And mention 3 ocular associations, okay? Okay, خلاص. Finished? Can we have the papers, please? الله يعافيك يعطيك العافيه كيف حالك الله يسلمك خلاص. Do we have all the answers? يلا please sit down. دكتورة خلصنا؟ خلاص يلا. يلا دكتورة. طيب يلا أبغى I want one of the R1s to answer. Where are the R1s? I know where you are. Raise your hand. طيب, who wants to answer this question from the R1? Let's start from any of the males. يلا دكتور تفضل. Okay, what do you call it? When it is non-healing? Persistent epithelial defect. ممتاز. What are the possible causes? أعطيني anything. طيب. طيب, okay. 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 ممتاز. Okay, طيب, الفيميل سايد. دكتور رغد, where are you? ديما يلا anything يا ديما. نعم any cause أي الأشياء اللي كتبتها أي شيء. طيب okay, diabetes is good. Dry eye is an excellent answer. إيوه okay, ممتاز. R2, where are you, R2? Okay, إذا something related to inflammation, صح? Like a VKC related, ممتاز. غالبا الهربتك ممتاز. غالبا احنا يعني الكلاسيفيكيشن اذا جيتوا تذكروا اسباب افضل طريقه انكم توزعوها انكم مثلا تذكروا انه it's related to something inflammatory على سبيل المثال، وتذكروا منها اللي هو الدراي اي نسميها كيراتوكونجكتيفال سيكا، ممكن تكون related to rosacea، ممكن تكون related to احد ذكر chemical injury or chemical burn. Any autoimmune disease can cause this. and another category of يعني of etiologies اللي هو neurotropic اللي انتم ذكرتوه اللي تشمل الهربتك وتشمل الدايابيتس وتشمل الرايلي داي syndrome. إذا في long list of causes ممكن تكون related to mechanical مثلا زي ال VKC مثلا either related from the papillae or إذا كان في كان في eyelid lesion, trichiasis and so forth that is impeding the healing. or ممكن تكون حالات اللي هو anything that could lead to limbal stem cell deficiency من ضمنها اللي ذكرتوها اللي هو drug toxicity or chronic use of يعني local anesthetic. طيب R2 مين في من R2 يلا تفضل دكتورة. MK related endophthalmitis. طيب ما أسمع.
So this is an microbial keratitis, probably associated with endophthalmitis.
Okay.
Management would be, my first was to rule out endophthalmitis with B scan.
Okay.
Admit the patient, do scraping.
أول شيء في المانجمنت أول شيء لا أول شيء management is a broad term and that's why I use this word.
Broad
You start
term.
with history صح? You look
أي.
for the risk factors.
أي.
Is it trauma related? طيب. Is it related to contact lens wear?
Yeah.
Is it something related to herbal? لأنه this will set your diagnosis. طيب. It will help you differentiate. Is this related to viral? Is this related to bacterial? Is this related to fungal? خلاص. طيب. It will help you establish some sort of route بحيث إنك you can start your management.
Yeah,
So
true.
history, you look for the risk factors. صح? You look for the onset.
Yeah.
طيب. Okay, go on.
History of trauma. تبغاني امشي بالهيستوري
قولي.
كذا؟
Yeah.
Okay.
Sure.
في الهيستوري الهيستوري of trauma, use of contact lens.
تسمعوها؟
أول زي اللي قلت fungal.
Okay, local
Herbal.
anesthetic abuse, the whole list. خلاص.
Yeah.
And
Ocular
then
surgeries.
ocular surgeries ممتاز. طيب بعدين after
Okay, for
that
physical examination, the VA is most important.
ممتاز.
What else? And look for, then do the microbial keratitis. Look for a CED, measurement of the microbial keratitis. This looks like a feathery margin, circular MK, related with the hypopian, probably like 1/3 of the cornea.
Okay.
What else?
طيب the way to answer this is you say as you mentioned بالنسبة للphysical examination I want to check the visual acuity, I want to check the intraocular pressure. طيب خلاص. And then I will document the characteristics of the infiltrate. خلاص. The size of the infiltrate. إذا في melting ما في melting, CED, no CED. خلاص. Measure the hypopian. Okay, and then during the examination what will you do? You will look for endophthalmitis. You will
yeah.
dilate and you will
Dilate.
see the red reflex.
Yeah.
صح? You will try to see the vitreous if
Yeah.
you can. طيب, and then
Do scraping.
if you cannot see the أول شيء تذكري after if you cannot see the
B scan.
fundus you say the B scan مباشرة بعدها to rule
Yeah.
out endophthalmitis is critical.
Yes.
It's a red flag usually في oral exam. It must be said and you have to rule out endophthalmitis. خلاص أيوة. You do the scraping.
Yeah. And then give fortified antibiotics.
You do the scraping for stains and for cultures.
Yeah.
طيب, you have to give the full word خلاص and
Yeah.
I'm doing scraping to stain
Yes.
and to culture. And then I will ask you what stains are you going to send for?
GIMSA.
Okay.
و H&E stain.
جرام and جمسة صح؟
أيوة،
هذا
جرام
البيسك.
أيوة.
طيب and then you'll send for culture
Yeah.
اللي هو البليتس اللي نحن عارفاه.
أيوة.
خلاص؟
أيوة.
And then after that, you will admit, as you mentioned.
Yeah.
And then,
Give fortified antibiotics C5
okay. طيب.
and if there is an endophthalmitis, I will do
طيب.
intravitreal antibiotics.
When are you going to start the fortified antibiotics?
After scraping. على طول.
After scraping. Usually إنه غالبا الادmission it takes a couple of hours إن
Yeah.
البيشنت يطلع فوق و cleared by medical. Usually start him in the emergency room. Okay. طيب. Third question. R3 please. R3. دكتور تفضل.
عليكم.
عليكم السلام. دكتور عبد الله أعطيني description قبل ما تعطيني diagnosis ها.
So the first photo at the top is showing a slit beam or slit lamp photo focused at the IOL and showing turbidity behind the IOL.
Okay, good.
The one at the bottom is anterior segment OCT. It is showing also turbidity behind the IOL.
Okay. طيب, so what is your diagnosis now?
Post-operative capsular plug syndrome.
Okay, capsular block syndrome. Okay. What is the answer? What's the nature of the fluids? This can happen intraoperatively. We all know this, صح?
Yes.
It can happen intraoperatively. And it can happen, we can find it in the early phase post-op, within the first week. And we can find it late, within 3 years, 4 years. So intraoperatively, what is this fluid?
So when it happened, intraoperative capsular plug syndrome, usually it happens when the lens is in place before removing the lens.
Okay.
And it happens during hydrodissection. By BSS, it accumulates behind the lens.
Okay.
And later with manipulation it causes rupture of the posterior capsule.
Okay, good. ممتاز. غالبا يعني هو the reason why the fluid يعني is blocked behind the lens is that there is high irrigation pressure, especially if you have a small capsulorhexis. So the fluid will be entrapped. It cannot pass through and through. Okay, so it becomes blocked behind the lens. And with this high pressure, there is a chance that the posterior capsule might rupture. Okay, so this is intraoperatively. طب early post-op, within the first week, let's say.
So usually what happens is that viscoelastic accumulates behind the IOL, and the surgeon usually fails to remove it completely. So this leads to just presence of clear viscoelastic behind the IOL. This does not cause usually a significant compromise of vision, except there might be just hyperopic shift in this patient.
Is it hyperopic?
Sorry, myopic
myopic
shift.
shift. خلاص.
And the late
Capsular block usually induces myopic changes. خلاص, it's an extra curvature, so it will induce more power and a myopic shift. خلاص, هذا في الكبسة at any stage. It is a myopic shift. طيب, so early post-op, as you said, Dr. Abdullah, it is usually viscoelastic entrapped between the IOL and the posterior capsule. خلاص, and it's usually clear, more clear than this. طيب, لكن this is a late case. There is another scenario or another possibility or another theory why fluid accumulates behind the IOL. If it is viscoelastic, usually time it will resolve, it will go away. خلاص. The other scenario in the early post-operative phase is that you have some remnant lens particles, and these small particles induce some osmotic changes. يصير في fluid collection نتيجة الأوزموتيك gradient الموجود. This is one of the theories يعني أو one of the possibilities that can happen in the early post-op phase. لكن غالبية الحالات اللي نحن نشوفها is related to viscoelastic. طيب, في late onset 3 years from now.
So this accumulated fluid usually gets turbid with time.
Okay.
And the turbidity usually just causes obstruction of the visual axis.
طيب, so what is this fluid? Or يعني what is this? How ليش تجينا بعد 3 years with capsular block?
Just from the stagnation of the fluid that is blocked at this area, and with the proliferation of cells residual from the epithelium of the patient.
Okay, so the answer is from residual epithelial.
From the lens.
Yes, epithelial cells. وغالبا الفلويد is turbid because it is high in beta عفوا alpha crystalline. خلاص لأنه it is produced by the epithelial cells of the lens, the residual ones. خلاص. So this is in case of late onset. طيب what is the management? Any other R3? أحد يجاوب؟ R3. What is the management? Yeah, capsulotomy or نعم observation, yeah, capsulotomy or
Pars plana removal.
pars plana. Yes, good. Okay. طيب, what is the diagnosis? R4? R4? Any of the R4s? دكتورة؟ بدور. Okay, excellent. نعم. This is actually conjunctival melanoma. You said it, it's a raised lesion. PAM should not be raised. خلاص? Primary acquired melanosis should not be raised. One of the earliest signs that you suspect that a PAM became a conjunctival melanoma is when it thickens, okay? So this is a raised lesion. You can see it's like a nodular lesion and you can see the vessels, خلاص, going toward it. So this is a conjunctival melanoma. طيب, a conjunctival melanoma, you said one of the sites of origin, so it can arise from PAM or de novo or from a conjunctival nevus, صح? So this is a conjunctival melanoma, okay? It is a raised pigmented lesion and you can see the vasculature going towards it, خلاص? So it arises usually or can arise from primary acquired melanosis or de novo or from a nevus, okay? غالبا it arises from a pre-existing PAM, okay? طيب, which one of those three in حصل it arises from it will have the highest risk for metastasis and death? De novo, okay? So if you have a conjunctival melanoma that arises from de novo, okay, it has the highest risk for metastasis and death. Excellent, okay. طيب, another R4, نبغى another R4. R4. دكتورة روان. Who wants to answer this? دكتور? Okay, excellent. ممتاز. Okay. Okay, so you said hyperopia, good. Cornea plana, glaucoma, طيب. It can also come with clabomas, okay? يعني there is a wide list of ocular associations, but these are the most common. خلاص? So how was the quiz? Was it okay? Okay, good. طب خلينا نصلي بعدين نبدأ الأمنم. الله يعافيكم. كان صعب؟ في صعوبة؟ ايش اللي أنا عارفة أنا متعمدة أحطها variation بس عشان تتعودوا يعني. I will be generous with the marking ما تخافوا بس إنه. ما في مشكلة. هذه طبعا هذه جنكشن وكذا هذه بالنسبة للنيبس. أيوة. بالنسبة للميلانوما. وعليكم السلام، يلا نتحيي، كيف حالك؟ الله يسلمك. بالنسبة للميلانوما إذا أنت you want to categorize it then you go to the AGCC classification خلاص اللي هو T1 T2 لأن خلاص ميلانوما طيب ما تقدر تقول لي إنها جنكشن ولا لا أنت اعتمدت إنها نيد بس بالدايجنوستس ما في إشكالية هي يعني أنا تعمدت أذكر أشياء معينة أنا عارفة إنه when you're studying أحيانا الواحد تجي بعض الأسئلة المكررة ما عاد يقرأ في الأشياء الثانية وتنصدموا بعدين في الأورال. So this is just a way just to expand. الله يعافيك. حياك الله. طيب 10 دقائق خلينا نصلي ونرجع.
شو تحب حق تشوشوت؟
عادي تشيل الانتيريور كابسول كثير. طيب غالبا يعني لا غالبا اذا كان anterior capsular tear you have other options. اما انك تجرب تحطها جوا الباك وتشوف اذا ستيبل ولا لا بالديفيز. اذا ما مسكت ممكن تحطها لانك لو حطيتها في الانتيريور كابسول يعني تسكس ما حتمسك ما حتكون ستيبل. ممكن ايرس تتسيب خلاص. فهذه اي طيب anterior capsular extension to the posterior tear ممكن يعني this is an acceptable reason خلاص. بس anterior capsular tear بحد ذاته يعني ما لا 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 هذا من عندنا خط شيء ما it's not relevant. It's not you have بالضبط ايوه انت you are lying on the anterior capsule for support. تخيل انه مثلا عندك بس the inferior half is present and the superior half is absent وجيت تحط الاي او اف طيب بتصير مايله. طيب خلاص في هذه الحاله غالبا الأبط ما راح ترانسفير التكتيك نروح نحط سوتشر على الايرس خلاص ايرس تصير تشيل التكتيك. طيب ف it is mandatory إذا يكون في good anterior capsule تشيل خلاص. خلي الانسان دي تختلف الآراء وتختلف السهول ويختلف الكلام. طيب خلاص you can إذا في you can visit إذا كان في weakness you can visit the back either using 3D or CTR. طيب وCTR بتشيل إلى ما عندك مشكلة. طيب هو غالبا زي مثل الحالة هم دخلوا حطوا CTR ودخلوا بس إنه ما كان المشكلة كانت على الأنستيك فغيروها حطوها فوق
Assalamu alaikum. Good afternoon, everyone. It's my pleasure to present the M&M case under the supervision of Dr. Noor Al-Khariji, whom I would like to thank her for her kind supervision. So our case, she's a 70-year-old female, known case of diabetes, hypertension, dyslipidemia, and rheumatoid arthritis. She presented to the clinic complaining from gradual degrees of vision over several years. On examination, her vision was counting finger and 2200 and 2100, and she was having nuclear sclerosis plus 3 in both eyes. So the impression was visually significant cataract, and the plan was to go for phaco plus PCIOL in the right eye. So during cataract surgery, during emulsifying the last quadrant, a PCR occurred, and the last quadrant dropped in the vitreous. Anti-vitrectomy was done, and the wound was free of vitreous. 3-piece IOL was inserted in the sulcus, and the main wound was sutured with 10-0 nylon. Day 1 post-op, the patient presented with counting finger vision. There was 2+ corneal edema, and suture was in place, no leak, with 2+ AC reaction, mainly pigmented, and their impression was stable post-op. The next day, the patient presented to the ER complaining from severe pain in the right eye. So her vision was hand motion. She was having no lid swelling, 1+ corneal edema, 4+ cells, and 2+ flare. The iris was round, regular, and reactive. PCIOL was in place. The fundus view was a bit poor, but yet there was a read reflex. So their impression was severe post-op inflammation in the right eye, and since she's like complicated case, they plan to admit the patient, started on PRIT 40Q 1 hour, and atropine TID. Next day, the patient vision was hand motion. There is absent read reflex and 1 millimeter hypopyon. So at that time, their impression was acute postoperative endophthalmitis, and the plan was to inject her with intravitreal injection of vancomycin and ceftazidime. Next day, they shift her to the OR to do for her AC washout, PBV, intravitreal antibiotic, and removal of the last quadrant that have been dropped in the vitreous. During surgery, they found retinal necrosis, sclerosed blood vessels, and a pale disc. Culture was negative for her after that, and the patient was stable after that with a counting finger vision near face. So this is a fundus photo of the patient showing the pale disc and the sclerosed blood vessels, and she was stable. So I'd like to talk a few about the endophthalmitis. So endophthalmitis is an inflammation of the internal structure of the eye, and can be infectious or non-infectious. It can be exogenous when the normal anatomy boundary of the eye have been violated, or endogenous, like occur by hematological dissemination. Endophthalmitis can be classified as acute postoperative endophthalmitis, delayed onset endophthalmitis, late postoperative endophthalmitis like blip-related endophthalmitis, and post-injection endophthalmitis. And here we can see the causative organism of endophthalmitis, and we can find that Staphylococcus epidermis is the most common cause for acute postoperative endophthalmitis. So acute postoperative endophthalmitis usually occur between 2 to 11 days following an intraocular surgery. Usually patient will present with pain and or decrease of vision. And the sign, usually they will have lid edema, conjunctival injection, corneal edema, anterior chamber flare, cell, hypopyon, or fibrin reaction. And the vitreous, it can have some vitreous cells, retinal infiltrate, hemorrhages, periphlebitis, and later on they will have dim read reflex and no view to the posterior pole. And it is common in prolonged cataract surgery, especially when complicated by posterior capsular rupture and vitreous loss. So the differential diagnosis for acute postoperative endophthalmitis can be lens-induced uveitis, either like if part of the lens have been remained in the eye, or the anterior capsule have been violated after trauma. Usually patient will present with keratic precipitate, posterior synechiae, and elevated intraocular pressure. Toxic anterior segment syndrome, which will have like diffuse corneal edema, usually occur between 12 to 48 hours after surgery, and can be related to either the irrigating saline or the sterilization of either the lens or the instrument used in the surgery. and anterior uveitis or non-infectious inflammatory endophthalmitis that can happen 12 to 48 hours after intravitreal injection. So this is the difference between toxic anterior segment syndrome and infectious endophthalmitis. As we mentioned, that toxic anterior segment syndrome usually happen between 12 to 48 hours, while in endophthalmitis 2 to 7 days. Most patients experience no pain in toxic anterior segment syndrome, and usually they will have diffuse corneal edema, unlike the infectious endophthalmitis. Anterior chamber, they will have cells, flare, and fibrinous reaction. Pupil might be like atrophic and fixed dilated. Vitreous usually will be clear, unless there is like spillover from the anterior chamber reaction. Where in infectious endophthalmitis, there will be opaque media. So after diagnosing patient with endophthalmitis, we need to take sample to do stains and culture for them. And we can take it either from anterior chamber tap, which can have 33% culture positivity, or from the vitreous, either by needle tap, which can give us from 50 to 60 culture positivity, or by taking vitreous, either by office-based vitrectomy or in the OR, and have a higher culture positivity from 70 to 80%. So regarding the management, I would like to talk briefly about the endophthalmitis vitrectomy study. It's a prospective randomized multicentral trial. Their objective to know whether the use of intravitreal antibiotic improve the result of intravenous antibiotic improve the result of treatment. And the second issue, whether the performance of immediate Parsaplana vitrectomy improve the result of treatment. The reclusion criteria, patient with endophthalmitis within 6 weeks who underwent cataract surgery or a secondary IOL implantation. So they randomized the patient into two randomization. The first randomization was to divide the patient whether to go for vitreous tap or limited biopsy with intravitreal antibiotic, or immediate core Parsaplana vitrectomy with intravitreal antibiotic, and they use vancomycin and amikacin. The second randomization, patients were receiving intravenous ceftazidime and amikacin, and the second group received no IV antibiotic. The result, there was no improvement in vision result with the use of intravenous antibiotic, and they have more than one explanation. The first, they said that if you give the patient immediately the medication into the vitreous, it will have more effect than systemic antibiotic. And the other thing, they're using both antibiotics that cover mainly the gram-negative, which is amikacin and ceftazidime. The second result, there was no difference between tap and inject or immediate vitrectomy in patients with presented vision of hand motion or better. So if you have a patient who's having hand motion or better, it's better to go for tap and inject and keep evaluating the patient rather than going immediately to Parsaplana vitrectomy. And the third result was immediate vitrectomy, however, achieved better outcome for patients with light perception vision at presentation. So if we have patient better hand motion or better, it's better to start with vitreous tap and then injection. If it's light perception or worse, it's better to go immediately for Parsaplana vitrectomy. So what about the steroid? Steroid, honestly, it's a bit controversy, but the rationale behind using a steroid to decrease the inflammation which can be as destructive as the infection itself. And in such intravitreal steroid, we prefer to use short-acting steroid like dexamethasone, not to like induce more infection or enhance the infection in the future. This is a systemic review looking at the use of intravitreal steroid with the antibiotic or using the antibiotic alone. And it was a systemic review, and they conclude that the current evidence on the effectiveness of steroid and antibiotic, it's we can't really it's inadequate, and it is not possible to conclude whether the use of adjuvant steroid is effective at this time. So further study need to be done to know whether intravitreal steroid adjuvant with the antibiotic is helpful or not. So how can we prevent endophthalmitis from happening? First, it starts with the proper diagnosis and treatment of any periocular inflammation or infection, like blepharitis, conjunctivitis, dacryocystitis, and proper treating this condition will prevent, inshallah, endophthalmitis. Other way of preventing is 5% povidone iodine and isolation of the eyelashes with the adherent draping during surgery, intracameral antibiotic usage, and watertight sealing of the wound and prevention of hypotony either by suturing and making sure there is no like oozing from the main wound at the end of the surgery, and post-operative antibiotic, whether topical and subconjunctival. So this is another study showing the usually we face patients with suture and we would like to remove the suture, and we don't know whether we really need to put any like povidone iodine, Oflox, or chlorhexidine. So this study, they bring 3 groups of patients at the clinic base, and for each group, they put in the first group povidone iodine in one eye, and in the second group, they put Oflox, and the third group, they put chlorhexidine. And the other eye served as the control. And then after they take a culture, and the result shows that dramatic or significant reduction of the bacteria after using each one of those modality. And the difference between those 3 modality were not statistically significant, so we can use either one. So in conclusion, endophthalmitis continue to be a source of considerable ocular morbidity. And proper evaluation of patient is crucial to prevent endophthalmitis, either pre-operative and proper examination post-operative. Extra precaution should be directed to all complicated surgery. So whenever we have patients with PCR, we need to be extra cautious looking for any sign and symptoms of endophthalmitis. Early detection and proper management is the key. Thank you very much.
When did he show in the emergency room after surgery?
Day 2 post-op.
Second day.
Yes.
Was the retina consulted
Yeah.
before he presents?
Yeah, since he's like complicated case, so
Yeah.
they were having like high suspicion of endophthalmitis. They don't want to miss early signs of endophthalmitis. That's why they immediately admit the patient, start him on heavy like Q1 hour Pret 40 and atropine with his antibiotic, topical antibiotic, and to observe the patient closely.
Okay, what I want to emphasize, whenever you have drop of nucleus, you have to consult the retina the same day.
Yes.
Okay, because if you leave it, whether it's quarter or nucleus will cause reaction. It should be removed.
Yes.
If it was cortex, it may be absorbed with time. Yes. But nucleus, the retina people should be adjusted the same day,
Yes.
Consulted, and they decide for whatever happens.
Sure.
Because sometimes if you leave the nucleus,
Yes.
with time it will give you severe reaction, which will simulate endophthalmitis.
Yes.
يعطيك العافية دكتور أحمد. Important point for the residents is proper pre-operative evaluation of your patient. If you are selecting a patient for cataract surgery or any procedure, you make sure that the lids are clear, so no blepharitis. Assuming the patient has severe blepharitis, don't go ahead and book him. Make sure you clear that first before you book the patient for OR. Another point is during suture removal, make sure that you instill povidone before removing the surgeon and giving the patients antibiotic after removal. Though this is a simple point, unfortunately, I found 2 patients who were not given antibiotic after suture removal. And this is important. Maybe these patients will pass clearly, but if there is a problem, it will come back to you, okay? So you make sure that you prepare your patients and pre-operatively and post-operatively. And as you mentioned, Dr. Ahmed, you be very cautious of the signs for early endophthalmitis, and you catch these patients, okay?
So thank you for the excellent. Thank you for the excellent presentation. With regards to I agree with Dr. Mansouri comments about consulting retina whenever you have a complicated case. It's important that the patient was admitted. This was the correct thing to do. Admitted, closely observed. Next day, follow-up is not enough. So he should have been, I don't know what happened, but maybe if I was the attending, I would have seen him the same day at least 3 or 4 times during the admission. With regards to systemic antibiotics, now we don't give IV antibiotics in the settings of endophthalmitis, but we do give oral moxifloxacin. This is not in the endophthalmitis vitrectomy study. It has shown good minimum inhibitory concentration when it is given systemically. We usually give 400 milligrams twice a day, the first day, then once a day until the patient is discharged. Regarding intravitreal steroids, in addition to what you showed, the literature review or the systematic or the meta-analysis that you showed, there is more recent paper that was published in ACTA. It is randomized trial, European trial, and it showed no benefit from adding steroids to the antibiotics. In fact, many people don't add steroids based on a study, I think in 2000, which showed worse vision in the steroids group. But here we still give intravitreal steroids whenever we have acute postoperative endophthalmitis. We have seen, based on personal experience, that the inflammation resolves faster, and it works, but the evidence is not with us until now. This is what I have.
Okay, thank you very much.
السلام عليكم ورحمة الله. طيب will not take long إن شاء الله. طيب بسم الله الرحمن الرحيم. الحمد لله رب العالمين. My name is Abdullah bin Ahmed, 4th year resident. First of all, it's my pleasure to present the M&M case and also for Dr. Noor Al-Khariji. I'm really grateful and thankful for her. My case is about a 75 years old lady present to the clinic complaining of decreased vision in the right eye for almost 1 year. And the past ocular history, she had cataract surgery in the left eye 3 years ago, and the past medical history is she's medically free. Regarding the examination, visual acuity showing counting finger for feet in the right eye, and is it 20/30 in the left eye, and the IOP is 15/13. Regarding the examinations, is the anterior segment is within normal, apart from that the iris shows a deposition of February white flaky material corresponding to the pseudo exfoliation in both eyes, and the lens shows a dense cataract in the right eye with pseudo exfoliation. The fundus was within normal in both eyes. So the impression was the dense cataract in the right eye, pseudo exfoliation in both eyes, pseudophakic in the left eye, status of CCC, and posterior chamber IOL. So the plan to go for phaco, BCIOL, OD under local anesthesia. Surgery was done. The operative report shows that weak zenule and phacodenesis were noticed after Provisic was injected to the anterior chamber, and the cortical material was removed using Simcoe. Superior zonular dialysis was noticed, and mild vitreous loss happened. Anterior vitrectomy was done. CTR was injected in the bag. Bag was filled with the Provisic. Then IOL IQ, 21.5 diopter, was injected in the bag but was not stable. So it was extracted to the ciliary sulcus instead of the bag. So the day 1 post-op status was phaco plus PCIOL, vision is hand motion. IOP is 41, stat was given, went down to 20. Examination showed mild subconjunctival hemorrhage, clear cornea, deep and quiet, and sulcus IOL with the subluxated inferiorly. Retina was flat. So impression is quiet post-op. The plan is continue same management to add Zeratan and to add Alphagan and follow up 2 weeks. Second post-op. The patient complained of pain on and off, and she is not compliant with the medication. The vision is counting finger, IOP is 19. The cornea is becoming edematous +2. The anterior chamber is deep and quiet. Sulcus IOL subluxated inferiorly as before, but the retina, the fundus was hazy a little bit. The impression is stable to continue same management, stress on the compliance and the follow-up 4 weeks. Third post-op. Patient complaining of pain and redness, vision is the same. There is +1 cells and the sulcus IOL is subluxated still. So B-scan was done showing one of the haptic is rubbing against the iris. So impression was iritis, right eye, plan to give cyclobentonate, Brit40 tapering, and follow up 2 months. Fourth post-op. Vision is the same, IOP is controlled. The AC is quiet now, and the IOL in place. The plan to remove the sutures and the flux given for a week and follow up 4 months. This is the last follow-up. So now I will speak about the ciliary sulcus fixated intraocular lens. Okay, first of all, when to use it. This is very important because sometimes the aim is to put the IOL in the bag, but sometimes you face scenario during the cataract surgery that will enforce you to put sulcus in the IOL in the sulcus. For example, if you have posterior capsular tear that is large enough to put IOL in the bag, it's not small round that you can put it in the bag, you can put it in the sulcus. Okay, and the second is if you have anterior capsular tear that extending to the posterior capsular tear. And the third, if you have zonular dehiscence. And all of these three, you have to have an adequate anterior capsular support to put it in the sulcus. This is very important condition to consider it. So now you decide to put sulcus IOL, and as we mentioned that aiming is to put IOL in the bag. So all the calculation that you have is to put IOL in the bag. So if you decided to put sulcus, you have to modify your IOL according to the IOL calculation that you have. So for example, if you have from -5 to +9, is there any change you have to do? And if you have +9 and until 17, you only subtract -5 diopter. And if you have 17 to 27, subtract -1. And if you have 27 to 35, subtract -1.5 to get the ideal IOL power. So now we'll speak about the characteristic of the IOL that can be inserted in the sulcus. We have 4 conditions that is give you ideal IOL to be inserted in the sulcus. First, that you have large optics. That is at least 6 millimeters. And why is that? To reduce the decentration and to permit better view of the peripheral retina. The second condition, that you have long haptics, at least 13 millimeters. This is to center the IOL. Then the third is you have thin, smooth haptics. This to reduce the scratching of the posterior iris surface. Fourth, that you have to have angulated haptics, and this will keep the optic away from the posterior surface of the iris. Okay. Now I'll just mention the type of the IOL that we have, the most common. I will mention the multi-beams. This is I present the 3 common of the Acrisoft multi-beam IOL. If we have here, this is the MA50, and we have MA60 and MN60. Let's go to the condition that we just mentioned. The optic is 6.5, which is better than this one that is 6 and 6. This one is 6. So this one is superior to these two regarding the size of the optic. If we go to the length, it's almost all of these 3 is the same. And if we go to the haptic angulation, we say that the angulation will keep the optic is away from the iris surface. This one is 10, and this is 10, and this is 5. So if we're going to choose from these 3, the MA50 is the best regarding these two. regarding the angulation and regarding the larger optic size. Just I have to say that I don't have any financial interest regarding these lenses. Now we'll speak about the sensor, the IOL. The optic is 6 and the diameter is 13 and 5 angulations. Also the thickness is almost the same. Now we'll speak about the single piece IOL. The accuracy of the command that we use is 6 diopter, the optic side 13, but it's not angulated. Okay. Also the other one, the thickness, all of these almost the same, is not angulated. So this is just side view of the single piece and the multi-piece. Okay, this is the multi-piece. So we can see it's a little bit thin and angulated, and the single piece is thick and also is not smooth as the multi-piece. This is just a review of the outcome of single piece intraocular lens implantation following posterior capsular ruptures. Is published in 2017, and the purpose was to assess the safety and outcome of single piece implantation. And the conclusion that this implantation is associated with higher incidence of complications, and single piece acrylic IOL are not designed to sulcus implantation, except in some scenario that is long axial. We will not talk about it. Complication of sulcus placement of single piece intraocular lens. This is another study. It was in 2009. This was to describe the complications, and they mentioned the complication that could be happen is the pigment dispersions, iris transillumination defect, dysphotopsia, elevated intraocular pressures with the UGH, uveitic glaucoma hypema, and intraocular hemorrhage and cystoid macular edema. And they conclude that intraocular lenses designed solely for the capsular bag should not be placed in the ciliary sulcus. These are just examples of the complication that can be happen if you put sulcus IOL single piece. This is showing the iris transillumination defect with pigment dispersions. This one, decentrations that can be happen also. This is also iris transillumination defects that is associated with high IOP. This is a single piece IOL foldable. It was extracted due to the complication that we have. This shows the anterior pigment granules deposition on the anterior surface of the lens, especially in the junction between the haptics and the optics. And the haptics and the optics, yes, sorry. So in conclusion, ciliary sulcus fixated IOL is an effective option in some scenario during cataract surgery. But you have to choose the ideal IOL to be placed in the sulcus and avoid the foldable single piece IOL due to the complication that we show you. And modify your IOL power according to the IOL power you have for the bag, and due to the location of the sulcus that is almost 0.5 millimeter anterior to the location of the bag. This is the references, and thank you so much for the listening. Any questions?
And I wonder why when they had vitreous lost and turned the posterior capsule, I would go ahead and put it in the sulcus and not put it in the back. Unless you have good zonules elsewhere and you put cyclotension ring.
So, Dr. Said, Dr. Samir, your options to what ciliary?
Whenever you have tear in the posterior capsule.
It wasn't. There's no any posterior capsule.
Okay, zonules devices.
Yes.
And you had vitreous loss. And you have done vitrectomy.
Anterior vitrectomy done.
So it's much safer that you go ahead and put it in the sulcus. You don't put it in the bag.
Yeah, but they was trying to put it in the bag, was aiming to put CTR to try to manage the weaker zonule that they have by CTR, but unfortunately the CTR that was placed was not enough to manage the weak zonule that we have.
So he put the CTR, then he put the lens.
They put them in the bag, but was decentered.
But after putting the CTR?
After putting the CTR,
okay.
They put in the bag, but was not sufficient to be deal with the weak zonule that we have.
And I agree with you that whenever you want to put a lens foldable in the sulcus, you should not put the one piece, because apart from being having, you know, it's more softer and it may be dislocated easily, but the 3-piece is the right one, whether it's the ones you mentioned. The other thing, when you have vitreous loss, you should do a good vitrectomy, because one of the causes of increase in pressure will be related to the vitreous. Whenever you have vitreous loss, you can have increase in intraocular pressure. So you do good vitrectomy to minimize, because it swells up, the vitreous itself swells up. And you can notice that most cases that have vitreous loss, the pressure will raise after surgery.
Sometimes the IOL bag complex drops inside. So you put the IOL in the bag with the CTR and everything falls down later on in life, and it is not easy to remove.
Yeah.
CTR removal inside the bag is another story.
One more point. It's important if you have a complication intraoperatively to be calm. You don't rush things. Not be in a state of panic. They placed the CTR, this is a good thing. Okay, they placed the foldable IOL and they found it was not stable, they removed it, this is a good thing. The next step is to remove this foldable IOL and place the appropriate IOL in the sulcus. So usually what happens, when you have a complication and then you have a sequelae of complication, is because you are rushed and you are panicking and you just want to close the eye. Okay, so take your time to assess the situation, step by step, and do the appropriate management. Okay, take your time. يعطيك العافية دكتور عبد الله.
شكرا لكم.
Assalamu alaikum. Good afternoon, everyone. My name is Mohammed Abu Saif. I'm a 4th-year resident. Today I'll talk about posterior capsule rupture during cataract surgery and morbidities that can follow if not managed properly. Before I start, I want to thank Dr. Noor Al-Khareji for her valuable time supporting and supervising this presentation. So the outline of this presentation will be starting with the case presentation, and then I'll follow with PCR prevention, detection, and management. So part 1, we're talking about our patient is 85 years old, female, known case of diabetes, hypertension, states post-CABG 1 year back. Presented to the cornea clinic complaining of painless gradual decrease of vision in both eyes since few months, mainly in her right eye. No history of previous ocular surgeries. Her ocular exam preoperatively show VA with 20/80 in both eyes with normal IOP. Her ocular exam show clear cornea with minimal corneal and peripheral scarring in both eyes. Deep AC with no iris in VIs. 3+3 nuclear sclerosis in both eyes. Dilated fundus exam show no diabetic retinopathy. No comment was mentioned about the pupil dilation or the presence of pseudoexfoliation in the file. So IOL calculation was requested, and then for both eyes, benefit and risk were discussed with the patient, and she agreed to proceed for cataract surgery starting with her right eye. The patient was cleared by anesthesia colleagues and booked for surgery. On the day of surgery, routine phacoemulsification was done till cortical removal step, where PCR was encountered with vitreous prolapse into the anterior chamber. Anterior vitrectomy was done. Multi-piece IOL was implanted in the sulcus with adjustment of the IOL power. 2 10-0 nylon sutures were used to secure the main wound and paracentesis. Post-operatively, 2 consecutive post-op visits, 1 day after surgery and 1 week after surgery, showed stable quiet eye with mild corneal edema. Sutures were in place and no vitreous in the AC, and IOL was in place. Vision was 2200, improved with pinhole to 2100, and improved further to 2080 with no visual aids on post-op week 1. So if you noticed, this case was managed properly, and here we are in an M&M presentation. The idea is to show you that PCR is very common, and if managed well, no morbidities will happen. Part 2, I will talk about PCR management. So the question to be answered on this second part are, what are the risk factors for PCR, what are the signs of PCR intraoperatively, and how to manage PCR at different stage. Why we should avoid posterior capsule rupture. Rupture of the posterior capsule with or without vitreous loss result in an increased risk of secondary intraoperative and postoperative complication, resulting in poor visual outcome. These complications include corneal decompensation, retinal detachment and retinal break, glaucoma, cystoid macular edema, retained lens material, long surgery time and patient discomfort, prolonged postoperative inflammation, and visual recovery. To start with, vitreous loss during cataract surgery is impossible to avoid in all cases. A retrospective review coming from Singapore was published in the American Journal of Ophthalmology in 2013, looked at rupture rate of posterior capsule between faculty and resident in around 50,000 cases over 5 years. It concluded that overall capsule rupture rate was 1.8%. Faculty rupture rate were lower than residents, but visual outcome were similar. 93% of all of these cases had VA of 20, 40 or more at 3 months, and the same thing was applied to the resident case, and this possibly attributed to case mix and close supervision. Rupture time were most frequently occurred during phacoemulsification, 60%, and INA in 25% of the cases. From this study, we can see that despite that PCR happened, but with excellent management, this did not prevent good visual prognosis at the end. Given the variety of pathogenesis presented by the human eye, even the best surgeons can have complication. In this study, around 100 cases out of 900 had PCR with additional postoperative complication like retinal detachment, desmin detachment, glaucoma, vitreous in the AC. Some prevent good visual prognosis at 3 months and necessitate further surgical exposure. So now we'll go to the first part of the second part. Prevention of PCR. Nowhere is the adage, an ounce of prevention is worth a pound of cure. درهم وقاية خير من قنطار علاج. More appropriate than when it comes to complication prevention during cataract surgery. So certain cases present a red flag for cataract surgeon. Any type of zonular issue is problematic. We should anticipate compromised zonular integrity from the clinic, especially after ocular trauma, with very asymmetric cataracts in eyes with pseudoexfoliation or anisymmetric anterior chamber, and in those that have undergone PPV or peripheral iridectomy. Very dense, pronounced, intumescent, small pupils, floppy irides raise the chance of capsular rent. We as a surgeon should diligently prepare for such complication. I will take one of these complications and then I'll go. So you can remember from basic math classes at school that the circle area equal pi multiplied by the radius of the circle. From this simple equation, you can know that the surgical fees is reduced by around 50% when the pupil gets smaller by only 2 millimeter from 8 millimeter to 6 millimeter, and 60% from 6 millimeter to 4 millimeter. So basically this states the fact that you are not seeing what you are doing, the edge of the bag, the equator, or even the rexus margin. So don't hesitate or have a very low threshold to place iris hooks. It will take 2 minutes, but it will prevent a PCR that will take maybe 1 hour. Causes of small pupil are many. To name some that we mostly face in our daily practice: diabetes, post-PRP where ciliary nerves are affected, and floppy iris syndrome. Small pupil management is one of the most important skills and knowledge cataract surgeons should acquire. Have a low threshold to use iris hooks. Pay special attention for pseudoexfoliation patients. They can have different variety of complications, preoperatively, intraoperatively, and postoperatively. You can see preoperatively they can have small pupil, pupillary synechia, zonular laxity, capsule fragility, and vitreous prolapse. Intraoperatively, iris damage, and posterior capsule rupture, capsular bag dislocation, even late. Postoperatively, they can have also fibrinous reaction, among others complications. The idea is a recent article published by Dr. As-Salih and his colleagues showed that the presence of pseudoexfoliation in around 22,000 cases was 3.5%. Other studies showed that the prevalence is around 25%. So in Saudi Arabia, you should rule out pseudoexfoliation before going to surgery. Signs of zonular weakness include phacodonosis, poor pupil dilation, asymmetry of the anterior chamber depth, asymmetric gap between the iris and crystalline lens, angle recession, lens subluxation, iris coloboma, skew lens nucleus, and pupillary transformation defect. This focal point module is an excellent reference in management of zonular weakness in details. Notice that we can predict that PCR might happen from the beginning of the surgery. In this video, you can notice that the physician or the surgeon facing difficulty initiating the tear. Notice how the wrinkles in the anterior capsule from zonular weakness, because there is no counter traction against the surgeon power or force. Notice that the surgeon is having very difficult time initiating the flap. It took him around 1 minute only to initiate the flap. Notice the tendency of the flap to tear out. So from this video we can see that anticipation of complication can be noticed from the beginning of the surgery, even intraoperatively. So one of my teacher, surgeon, taught me, he said never allow for vitreous loss to happen twice the same way. So try to record all your cases. PCR can happen with all surgeons, but it shouldn't be repeated with the same mistake. Knowing which patient is at high risk during clinical exam preoperatively and early intraoperatively is the key for prevention. Consent the patient for additional procedure if high risk was there. So the complication will be transferred from a complication to a part of the procedure. Now I will talk about recognition of PCR. A rupture in the posterior capsule, and in particular the anterior hyaloid phase, will change the pressure relationship between the anterior and posterior chamber and the posterior segment. This change in IOP in turn affects the anterior chamber depth, and often the pupil size will change. Notice here in this video how the pupil bounce, indicating a posterior capsule rupture and change in fluid. This is one of the earliest signs that you can see that the patient has posterior capsule rupture. Other signs and features, ominous feature of PCR is change in the anterior chamber depth during phacoemulsification or INA, inappropriate loss of flowability of the lens material, unexplained loss of phaco efficiency, tilt of the nucleus equator, spidering of the posterior capsule or unusually clear spot between the zonules and the posterior pole. Wound will not seal despite proper construction and peaked pupil. So once you encounter any of these features in PCR, declare code V at the back of your brain, and even practice this in fake situations so you can be ready once you need it. Do not withdraw the phaco instrument from the eye. Go to foot position 1. Maintain the chamber stability. Don't allow for the chamber to collapse. Fill the AC with enough dispersive viscoelastic through the side port to close the incision as you withdraw the phaco tip. Assess the situation, inspect, relax, think, and announce a delay. Now I'll speak about the management of PCR. Though the lens capsule is the thickest basement membrane in the body, posterior capsule is only 4 microns. So whenever you finish a cataract surgery uneventfully, you should be proud. Posterior capsule rupture can be placed in 3 categories: broken capsule with an intact anterior hyaloid, vitreous prolapse defined as vitreous within the confines of the anterior chamber, and finally vitreous loss through the incision. Retained lens material can add to these complications. So whenever you have a PCR, the ultimate goal when PCR happened is to clean the AC from vitreous to prevent intraoperative vitreous traction and postoperative traction, bearing in mind maintaining a normotensive globe, because vitreous follow the low gradient pressure. Protect the tissues, cornea, iris, capsule from collateral damage, and maintain capsular support for safe IOL implantation. Putting in mind these 3 goals, you will be able to perform safe phaco surgery with uneventful complication. I will pass by each type of complication in posterior capsule. So in this video you can see posterior capsule rupture, but there was no vitreous prolapse. And here we can notice that the surgeon is transforming a small rent in the posterior capsule into posterior continuous circular capsular excess. Here we can notice that the surgeon was able to complete the rexes perfectly in the posterior capsule, and he was able, actually she was able to implant the posterior single piece IOL in the back. While in this video we can see there is a large posterior capsule tear with no vitreous prolapse. If you notice that in the previous video we didn't perform anterior vitrectomy, in this video also the surgeon will not perform anterior vitrectomy because there was no vitreous loss, but because she was not able to transfer this small tear in the posterior capsule, a large tear in the posterior capsule to CCC, then trying to initiate the ciliary sulcus and fill it with viscoelastic, preparing for ciliary sulcus 3-piece IOL implantation. And here we can see the 3-piece IOL was placed in the sulcus safely and will center in the eye. Viscoelastic was done. So when we talk about vitrectomy in case of posterior capsule rupture, the questions comes to mind: is automated vitrectomy necessary always? Some of the surgeon, when there is a small strand of vitreous prolapsing to the AC, he will go with an intraocular scissor and cut the small vitreous prolapsing strand without any complication, and he will use viscoelastic to push the vitreous posteriorly, and he might implant the IOL, and he will implant the IOL in the sulcus. The question is anterior approach or posterior approach. When we say anterior approach, we mean that we will use either coaxial vitrectomy or bimanual vitrectomy from the anterior part of the AC versus pars plana anterior vitrectomy. And then the last question comes to IA cut and I cut A. I noticed that many of the residents doesn't know the difference between IA cut and I cut A. I will talk about this piece, and each one of these I will talk about it with a video. So IA cut means irrigation aspiration cut, and I cut A means irrigation cut aspiration. You will use IA cut when you are planning to remove the cortical material, small cortical material. You went inside the eye with the vitrector. Then you will use IA cut. You will hold the cortical material and then you will pull it and you will cut it. While in vitreous, you don't want to make any traction on the vitreous. So you will use irrigation and then you will cut the vitreous pieces and then you will aspirate it. So in this video, they study the effect and the difference between anterior approach and pars plana approach. Here we can notice that when we go through the anterior incision, more vitreous is coming and prolapsing. And because of low gradient, the vitreous is coming toward the wound. This is the more convenient for anterior segment surgeon, while through posterior pars plana approach, we can notice that we can use irrigation from the anterior segment and vitrectomy from the posterior pole. And then we will hit the vitreous from the back. This will prevent any vitreous from maintaining in the AC or to the wound. This is module I. There is controversy between surgeon, should we use this technique or the anterior vitrectomy technique. If you're able to manage the retina complication, then use the pars plana technique, which is better from this point of view. Otherwise, use the anterior segment approach. In this video, I'll show you another technique which is transforming the eye from unicameral eye to bicameral eye. Posterior capsule rupture happened. The surgeon will place the haptic in the sulcus and then the optic behind the anterior capsule, separating the posterior capsule from the posterior chamber from the anterior chamber. Anterior vitrectomy was done. This eye after trauma. Anterior vitrectomy is notice how the surgeon is trying to put the optic behind the ridge of the capsulorhexis. This video show triamcinolone assisted anterior vitrectomy, and also it shows that when we use a spatula to pull out the vitreous from the wound, we will make a huge traction on the retina and the vitreous base, causing retinal tear and retinal break. So never use this technique. Go with anterior vitrectomy, separate these two pieces from each other, and then with viscoelastic push the vitreous posteriorly. So when the remnant lens material should be removed manually. To consider phacoemulsification, you should ask yourself, is any vitreous going to come to the phaco tip? If the answer was yes, then convert. Otherwise, prepare the eye to prevent this. So it is essential there be no admixture of vitreous and lens material. Vitreous will preferentially be attracted to the phaco port, displacing the nucleus and preventing aspiration of the lens material. More importantly, the resulting inefficiently pulling is the danger of placing traction to the vitreous base with high likelihood of retinal tear. Unless vitreous can be isolated and compartmentalized away from the lens fragment, then the phaco handpiece should not be used to complete removal of the nucleus. The second condition is required is to presence of OVD, lens glide, or iris to cover any capsule break. So to make it simple, if you can isolate the vitreous from the lens material, and if you can put a glide or use the iris by constricting it, or putting the IOL first, separating the anterior chamber from the posterior chamber, then you can proceed with phacoemulsification. Otherwise, you should go and remove it manually. Do not fish for the nucleus. This picture will show you that this will make traction on the posterior, on the vitreous base. Actually, this technique where we use the BSS to float the nucleus pieces of the retina is used in rat to induce retinal detachment. Yeah. Sure. Okay. These two videos will show you posterior levitation technique versus viscolevitation technique risk. This video will show that if you use viscoelastic to pull the nucleus from the back, this will push it further behind the iris and behind the edge of the capsule. So any of these techniques is not advisable. So just refer the patient for retina surgeon, clean the anterior segment, and place the IOL. In some cases, we cannot implant an IOL. In these cases where we have a corneal edema or very large piece that will be removed later on through the anterior segment, then don't place IOL. The retina pupil will go in and push the lens to the anterior segment and will be removed with regular phaco. Post-operatively, refer the patient to retina immediately, steroid, and control the pressure, close follow-up. Thank you for listening. Any questions? Thank you.
Is very important. طيب, identifications of the signs for PCR is important. Options of management, clearly elaborated. Very well done, Dr. Mohammed. Today we had 3 excellent presentations. في أحد عنده أي سؤال؟